Please take your seats so we can get into the home stretch of this conference day. My name is Wolfgang Ischinger. I'm a career diplomat, and I've been the chairman of the Munich Security Conference for the last 7 years. You may wonder what my role as someone who's been dealing with peace negotiations, arms control, nuclear weapons, and the like, why I am sitting here. Well, in my profession, we thought that weapons of mass destruction, nuclear, biological, chemical, represented the gravest risk to humanity. I got really interested when I read, as many of you will know this better than I, when I read in a piece published by Bill Gates the following sentence: of all the things that could kill more than 10 million people around the world, the most likely one is an epidemic stemming from either natural causes or bioterrorism. That got me going, ladies and gentlemen. And then I discovered that we're actually discussing, under the rubric of global health, quite similar concepts as the ones that I've been discussing in my field of arms control and conflict prevention and international crisis for the last several decades. There are concepts such as we need global institutions, we need fast decision-making at a global level, we need to invest in R&D, we need early warning and detection systems, we need trained personnel, we need preparedness exercises, and I could go on. So let me announce that at the next Munich Security Conference, which is going to take place in early February of next year, for the first time, we will not only discuss Russia and NATO and Syria and the refugee crisis and the future of Ukraine and the use of military power, but we will discuss health security. We'll put it on the agenda because I think this is an important issue. Here today, ladies and gentlemen, we have a fantastic panel of experts. We don't have much time. We have 3/4 of an hour or less. Let me just briefly introduce my panelists. Ambassador Sezibera is the Secretary General of the East African Community. He's a trained physician. Secretary General of the East African Community means he represents an organization which brings together Burundi, Kenya, Rwanda, Tanzania, and Uganda. He has served as Minister of Health. He's been Ambassador to the United States, a multi-purpose gentleman. So welcome to you. Then to his right is Sir Robyn Murray from King's College London. So Robyn is a professor of psychiatric research. He looks at the risks of psychosis among refugees as a consequence of the trauma experienced during their weeks or months or years of plight and suffering. And he's regarded as Britain's most highly cited psychiatry researcher. Welcome to you, Sir Robyn. I think given our refugee problems at the moment, your expertise is particularly welcome. And last not least, Dr. Luis Loures, who is the Deputy Executive Director of UNAIDS for program. He joined UNAIDS many, many years ago in '96. He also serves as a member of the WHO Advisory Group on the Ebola virus disease response. And before joining the UN system, he served within the Ministry of Health of his home country, Brazil. So, gentlemen, we're not going to make long speeches, but what I would like to do is just give each one of you a few moments, a few minutes to make points. And of course, if I can start with you, Richard, to my right, in your view, what needs to be done so that we would be prepared better next time if that kind of a pandemic-like crisis breaks out? What were the most important steps that helped us to manage the crisis? And what are the takeaways? What are the lessons that all of us, not only Africans, the world should learn from it? You have the floor.
Well, thank you very much. First of all, thank you for inviting me to this session. I wish to thank the M8 Alliance and the organizers of this session. The East African community has about 150 million people. And we have had outbreaks of pandemics and epidemics, including Ebola, in our region for a number of years. In fact, Uganda has had 5 outbreaks. But you have not heard about them. We've had outbreaks of Rift Valley fever. We've had outbreaks of Marburg virus. You've not heard about them because we've been involved in doing a number of things which I think are critical if we go as we handle these pandemics and epidemics. Number one, at the national and regional levels, we've built a network of laboratories that help in surveillance on a constant basis. As a matter of fact, when the Ebola outbreak occurred in West Africa, in East Africa, we were doing field tabletop exercises in Uganda. And I think this is something that needs to continue. Second, we have set up an East African Health Research Commission that brings together all the research personnel within East Africa into, again, a networked environment where they work with their colleagues, but also have international support. And this is critical as we move forward. And third, health systems strengthening. Our countries are involved in investments in strengthening these health systems, including using immunization as a marker for health systems investment. I am happy that, for example, immunization coverage in many of our countries is approaching 90%, and for some of them is more than 90%. So there is no shortcut to investments in health systems at the national, subnational, regional, and international levels. Let me point out what I think we need to do to be ready and better positioned for the next epidemic or pandemic, because I know it will come. So the East African community has joined the Global Health Security Architecture. We probably are the only regional community that has joined this architecture of nations and organizations, because we believe that we need to move global health security to the center of international security. And I'm glad that the Munich conference will actually put an emphasis on this. First of all, we need to establish long-term surveillance mechanisms globally, locally, and regionally. We need stronger north-to-south and south-to-south collaboration. And I could go on about this one, but let me give you just one statistic. I mean, we heard today that the United States spends about $9,000 per capita on health. People who are invisible to all of us. They are invisible to health. They are invisible to policy. There are 3 categories. One are the children who are unregistered at birth. UNICEF estimates them at 230 million globally. These children fall through the cracks. They are invisible. We need to raise their visibility, and there is a way of doing it. There are millions who are invisible financially, and they're in resource-poor settings. They don't pay taxes, they own no bank accounts, and therefore they are invisible to decision makers, and this is a weak point. Therefore, we need to raise their visibility and deal with this issue. And finally, there are those who are invisible geographically. They are migrant populations, they are urban and peri-urban, they have no fixed abode, they have no UPS address, you can't find them on Google Maps. Some of them are using invisibility as a way of dodging state control. We need to invest in raising these people's visibility and then investing in their health, because if we don't do so, we shall not be able to meet the next epidemic or the next pandemic. Thank you very much.
Before turning to Sir Robyn, let me push you a little further here. I mean, you mentioned local awareness and educational issues. You mentioned organizational questions. You mentioned resource issues. If you had to prioritize these, which one would you put at the top from your point of view in East Africa? What's the single most important thing that needs to be done?
Well, number one is awareness. And number two is organizational ability to handle these matters. Awareness, because look at Liberia with Ebola. By the time the international community, by the time all of us intervened in Liberia, that epidemic was to a certain extent under control in some local areas where the people were aware. That happened also in Zaire, in the DRC, which neighbors East Africa. Outbreaks of Ebola are contained by the local communities because the communities are aware, the religious leaders are aware, the health workers are aware, and therefore awareness to me is number one.
Thank you very much. So Robyn, everybody here in Germany and in Europe is now talking about the wave of refugees. Healthcare issues, of course, have been discussed. How important are mental health care issues? Are we paying enough attention? How important is that? How traumatized are these people? What should happen? You have a microphone right there.
Thank you, Ambassador. Well, I think if you were to look at the agenda of this conference, you would think that mental health issues were not of any significance, because less than 5% of this otherwise wonderful conference has been devoted to mental health. And of course, that's about typical of the resources that are devoted by the major international organizations to mental health. It is much neglected. And yet we know it is vitally important. And we know, for example, that the people streaming out of the Middle East, or indeed people who've been migrating out of Africa for many years, have been subject to terrible traumas in the countries from which they're fleeing. They've been bombed, they've been living in fear, they've been assaulted, they may have been raped. So there is this high rate of post-traumatic stress disorder, which often prevents them from being able to get on with their lives. There's anxiety and there's depression. But I think and I guess that is pretty widely known, although not enough is done about it. But what is not known is the importance of the post-migration experience, going from one country to another country, fleeing the fear of fleeing across the Mediterranean, and then the attitude of the host community. And one of the things that's become apparent in recent years is that both refugees and migrants have much higher rates of serious mental illness, particularly psychosis and schizophrenia. And that's very dependent on their experience of their host community. That people who go in, for example, people of African origin migrating into European cities have 6 times the rate of schizophrenia. And this particularly in those areas and where people have experienced severe discrimination or the unpleasant attitudes of the host community. So in a sense, you can think of people perhaps moving into a northern European city as a child, being the teacher thinking that they were stupid because they couldn't speak English properly, the other boys in the class teasing them and bullying them because they had funny-looking hair, then not being able to get a job when they left school because of discrimination, and the police arresting them for hanging about the street corner with their mates. Now, you can teach people to become paranoid. If repeatedly you, as an individual, you experience society being against you, after a while you begin to think that it's against you and develop paranoid delusions, even when it's not against you. So I think it's the importance of the host community attempting to help to integrate refugees and migrants has not been fully appreciated. And in those areas where people are welcomed, the rate of mental illness is much lower than in those areas where people experience hostility.
So are you telling us that the receiving nations like Germany, Austria, France, and others that we're clearly not paying enough attention to these issues? Where should the mental health issue be on the list of priorities of our governments and of the institutions that take care of the refugees?
Well, it depends how much you want to spend. If you want to spend a very great deal, you will ignore these issues, because mental illness is very expensive. People who develop cancer or Alzheimer's disease, many of them die. Fortunately, people who develop Ebola or AIDS now will not necessarily. But people who develop schizophrenia may be ill on and off for 40 or 50 years. In Britain, the cost of schizophrenia is £12 billion per annum, much outweighing that of many other illnesses on which the government spends much more. So I think it's economically sensible to spend more on mental health in vulnerable populations such as refugees and migrants.
Very important lesson. Thank you very much. Now, finally, let's turn to you, Dr. Loris. Have we failed to draw the right lessons from the HIV/AIDS crisis a few years ago? What are the lessons that we should have learned? Let us benefit from your experience.
Thanks, Ambassador. Just a few points on yours. I think what we have learned from AIDS, don't limit yourself to the virus itself. Try to look at the factors that are actually making the virus as driving an epidemic. And that goes much beyond the biology, goes much beyond the effectiveness. In your point, for instance, if I look at health security, today I look from 2 points of view. The first one is the impact, definitely, that epidemics and the other major challenges may have in terms of human security, but also look at that from the point of view of how conflicts are impacting on health, on human health. This is what I mean. Take a holistic perspective. Don't look at the virus. Look at the context. The second lesson that I think made us come so far in terms of the AIDS response in a relatively short term was related to 3 points. The first one was data. Make sure that you are close to the reality, that you have real-time data, that allow you to capture events as they happen. It was the major failure in terms of the initial response to Ebola. When we learned about the epidemic, it was just too late. And that was a reality that we need to learn, not only for AIDS, but also. I was, 2 weeks ago, is the president of Kenya, in Kenya, with Uhuru Kenyatta, launching a new platform in terms of data, that what you call a situation room. We learned that from your words, from the security world. And in the words of Kenyatta, not to give you too much details, not the point here, he said, if I had this platform, if I have this, Ebola will not get me, because it's a real-time platform. Data. The second one is make sure that you build innovative partnerships. This morning, in this forum with the Global Health Partnership, a German institution, as you know, I engaged in a fascinating debate between the private sector in Africa and the private sector in Germany, basically addressing the issue of access to drugs, to communities, the two pharmaceutical sides in there. This is the kind of debate that we need to foster if we are going for health security. We do not have the solutions as we speak. Business as usual. We will not take as far as this ambitious perspective of bringing health as a security issue. That was a fascinating debate with many new avenues to go forward. Partnership is the second. My third, and I fully agree with Richard, what he said before, bring communities to the center. The AIDS epidemic has shown to us that we did progress. What was different, exceptional in terms of AIDS, was not only the devastation by the epidemic in its beginning, was actually the centrality of people living with HIV/AIDS, of communities of the most affected by the epidemic, to make policies to participate. Again, the same you can see about Ebola. What killed a lot of people, more than the Ebola virus, was the lack of trust by the communities affected. If you have invested on that, the consequence will be less. Thank you, Ambassador.
Thank you. I think if we have a few more minutes before our closing speakers show up, let me ask all three of you to offer your assessment. Should we need to be, of course I speak as a layman, I'm not an expert on either communicable diseases or on non-communicable diseases or on mental health care issues. Should we be worried when we look at, for example, demographic growth in Africa and elsewhere? Should we be worried more about the Ebola-type communicable disease pandemic, or should we be worried equally about, heart disease and lung disease because of tobacco and alcohol and all the other diseases that are killing people by the millions? Give us your views. Maybe we start in reverse order.
As I tried to mention before, Ambassador, I think we need to look beyond the disease. We need to start to look at what makes people sick. Take the issue of sexual violence today, for instance, as a weapon of war in many of the conflicts that we are operating with. A woman that suffers violence has a likelihood 50% higher of getting HIV than the woman that does not suffer violence. When you have that in epidemic terms, as you are starting to see, this is a very recent development in terms of conflicts, is sexual violence as a weapon. These come in catastrophic terms. And then I think, yes, you don't need to wait for the infection to help. You should not wait for people to be sick. Try to prevent on the events that happen. Last week, I was in Cairo in the first meeting of The countries in the region involved in conflict, the Syrians were in there, the Sudanese were in there, the South Sudanese, the Libyans, all of that. We convened this meeting exactly to see how we can deal not with HIV, because the rates are not that high in the Middle East at this time, but how we can deal to reduce the impact of sexual violence in these societies. And this is a very interesting discussion. We learn, for instance, from this forum there, with government, civil society, and so that we just don't have a clue of what's happening, for instance, in the areas controlled by the Daesh today, and in other areas. And then again, don't wait for people to be sick. We know what makes people sick. That's where we need to try to intervene.
Thank you very much. So, Robyn?
Well, maybe I could continue on that theme of mental attitudes and trust, because I think psychiatrists used to think that the majority of the population is sane and a small proportion is mad, is psychotic. But now we know this is not true. If you do surveys of the general population, paranoid ideas and wild delusions are really quite common. Actually, Nietzsche, the philosopher, said this. He said, insanity in individuals is rare, but in groups, in parties, in nations and epochs, it's the rule. And you can think, actually, to Germany in the 1930s, when there was a collective delusion, paranoid delusion about Jewish people, or the McCarthy era in the United States when they were looking for Reds under the beds. And you can think how many of the conflicts that arise today and give rise to the refugees and the spread of illness, how many of these arise from paranoia about the stranger, that we as a human species are suspicious of people who are different to us by nationality, ethnicity, or religion. And I think you can also see this in relation to our attitudes to refugees. And of course, this is probably the millionth time this has been said at this conference. It's wonderful to see the attitude of the German government and population to refugees. And this contrasts with the paranoid attitude of Hungary or my government. The British newspapers are full of fears about the refugees and migrants are going to come and steal our jobs. They're going to increase crime. They're going to spread disease. So these paranoid beliefs that we have about other people, I guess you must have dealt in resolving conflicts, that quite often the dispute is not just about territory. It's about the fear of one country or against another country. And I think this informs it misinforms our attitudes to migrants very much.
Well, let me, in response to what you just said, let me simply say my own experience has been as a practicing diplomat that, of course, the most important but also the rarest commodity, not only between human beings, but between states and within international organizations, is trust. And it is so easy, as we find out over and over again, to destroy trust practically overnight. Rebuilding it, in my experience, between individuals, but even more so between nations, takes a huge amount of energy and time. That's what we're engaged in at this moment in Europe, and it's going to take a long time. But I didn't want to stop you from offering your comments, Rich.
Well, maybe I should continue with that theme of trust or lack of it. My biggest worries, in terms of global health security, is that we will not be able to detect the next epidemic in time for lack of investments in detection mechanisms at the global level. And second, that even when we do detect it, we shall discover that it is resistant to all the arsenal we have against diseases. So microbial resistance, maybe it will be resistant to the drugs that we have out there. So that is the second nightmare scenario, if you will. And the third would be that it would occur in an invisible population. To me, those three are the things that should really keep us awake. Well, during the day we should be awake, but it should also keep us awake at night. Because if you look at all the outbreaks we've had, certainly on the African continent, they've had those three components. The latest one they all occur in populations that do not appear on the radar screens of their governments. Ebola is the most recent one, occurred in an area where, in a disputed area, not really disputed, but post-conflict area, the borders between three countries, where the people were moving back and forth, no registration, so really invisible, both to the local authorities and to the global community. It has happened. As I said, our experience in East Africa has been that is where the outbreaks occur. All cases, and I do not see any evidence out there that shows me that this will not continue to occur. So the nexus between lack of investments in detection capabilities, resistance to what we have in the fight against these diseases in invisible populations, those I would suggest should be your themes for the Munich Security Conference. Thank you.
Thank you very much, and thank you for your patience and your interest. This concludes our discussion here. I would have loved to continue, but I need to look at the watch. The event is supposed to be closed by 6 p.m. As I invite the two co-chairs to join us here to offer their concluding remarks, let's offer another round of applause to our panelists, please. And you stay here.
First of all, thank you very much for this most interesting concluding panel. And I'm sitting here with my two colleagues, the active president of the World Health Summit 2015, Shunichi Fukuhara, you know already, Dean of the faculty in Kyoto University, and Antoine Flahaut, who moved from Paris to Geneva, the health capital, and is responsible for public health and global health at the University of Geneva. Ladies and gentlemen, we started this meeting Sunday morning, 8 o'clock, and starting with workshops, having the impressive opening on Sunday evening, and then worked hard in workshops, plenary sessions, and panel discussions on Monday and Tuesday. And now this World Health Summit 2015 comes to an end. And the question, of course, arises, what follows? I think the last two sessions showed that indeed something has to follow. There's the COP meeting 21 in Paris, and the Munich Security Conference will go on, and there are other challenges ahead. And we'll use the next 2 minutes really to show what we feel we can contribute. And one point, of course, is having the results summarized. And you may have noticed that in all workshops, and actually in the plenary sessions, we had rapporteurs. We're going to write up what has been discussed. So all your discussion, your remarks, your suggestions will be on record. We'll have a interactive website where you can contribute and we can interact. And as a first result, we have a so-called M8 statement, which is the traditional result of the summit. As we end the summit, we have prepared that, of course, but we have modified according to the results of the discussions. And the results of this M8 statement in a brief summary will be presented by Shunichi Fukuhara, the acting president. But let me know, this is not the end. Let me tell you, this is not the end. We'll have other statements. We have summaries of the discussion groups. We have summaries of the workshops and some of the plenary discussions, which will be forwarded to those who are interested or who should be interested. So may I ask, first of all, do we have a slide? I can't see that. Yes, so that's the M8 statement, and this is available on the website as of now. If you leave the room, it will be available, and Shunichi will briefly tell you what this contains. Shunichi.
Hello. First of
Just speak. It's on. It's on.
It's on? Okay.
Yes.
First of all, I really would like to thank you, all speakers and chairs, and all of you who made this summit most successful as ever. This April in Kyoto, we had a successful regional meeting, and we concluded Kyoto Fukushima statement. Since then, our spirit and the vision has been consistent. Today, we are pleased to announce the statement from this summit. As you see, and the most important keyword is, again, action. This statement, in this statement, M8 Alliance member calls for action on these 5 areas. As you see, the health of refugees and other forcibly displaced persons. Number 2, global health security, sustainability, and solidarity. Number 3, universal health coverage. 4th, climate change and health. And 5th, digital health. Please look at the website for details of this statement. Well, it has been a pleasure to act as a president at this summit. I look forward to assisting next leadership over the next year. Antoine.
Thank you, Detlef. Thank you, Shunichi. Ladies and gentlemen, I'm very proud and honored to be the incoming president, the president of the World Health Summit for 2016. If you see the 4 flags, the 3 of us are more or less, we can say, representing here France, Germany, Japan, and Switzerland. They are for 4 countries who benefit from life expectancy above 80 years. The world we want is that everywhere in the world we may benefit from a healthy life expectancy above 80 years. And for that, I think that we can remind the world Shunichi often says, action. Action for demonstrating our commitment. There is no better place in April, 19 to 21st of April, to go to Geneva, the capital of global health, where WHO, but also many UN agencies, but also NGOs committed in trying to provide better access to health for all, will be present also. So the World Health Summit Geneva meeting will be hosted by the Geneva Health Forum, a 10-year which will celebrate its 10-year anniversary at that time. And we will all be focused on the same spirit as the World Health Summit wants to focus on: science, innovations, policy, bridging policy and scientists and academic also with the non-academic world. And we will be focused on sustainable and affordable innovation in healthcare. So please, you are very welcome. Herzlich willkommen in Genf. And my last word will be also to say that you know that we have a meeting every year in the fall in Berlin. So save the date. That will be October 9, 11th, 2016 in Berlin next fall.
Thank you. If we conclude the World Health Summit 2015 now, this certainly does not mean that we have answered all the questions, that we have found all the solutions. There has been the suggestion that we should continue a question and answer period. But the majority of those who have approached me said, we have worked very hard the last 3 days. Of course, the discussion goes on, the search for answers goes on, but at this point of time, I think it's a time to thank those who have been involved. First of all, I would like to thank those who have worked behind the themes, the scene, all those who participate in the organization of the meeting. I'm not going to mention any of the names because I would have to mention them all. All contributed equally according to their positions. But it's the World Health Summit Foundation team here in Berlin. It's all the colleagues of the M8 Alliance. It's those who supported us here locally in Germany, the Charité, BIH, and others, the German government. And it's those supported us, partners around the world, to set up the program. Especially, I have to thank the audience. I mean, what is a meeting worth if there is nobody listening, if there's nobody discussing what we have prepared, what the speakers have prepared in their speeches? So all the 1,800 participants, 1,800 discussants, either in the workshops, or in the plenary panels or plenary discussions, or in the corridors during coffee break. Thank you very much. You have contributed a lot. Without you, the meeting would not have been worthwhile. And let me just take the last plea of Ms. Menne when she said there are actions to take, right? And the WHO plea to sign the WHO website for inclusion of the theme and topic of health in the climate discussion would be a first action which you can take now, and there are further suggestions, actions which you can take the following days and until the next meeting and certainly until the next Munich Security Conference. Thank you very much all and have a safe trip back. Thank you.